Good morning and good afternoon, everyone. Thanks so much for joining our open office hours for AIM3 demonstration and sustainability, as well as some questions. We're going to go ahead and get started and let everyone continue to join. My name is Francesca Flores. I will be your facilitator for today. You can chat to me privately by selecting my name from the drop-down menu on the chat list, or you can ask a question to everyone by selecting everyone. Briefly, today's agenda, we're going to talk about measure improvements. We're going to hear an implementation story from Gallup Indian Medical Center, and then we'll go into AIM3 definition reviews and a demonstration of the tools that we'll provide, and we'll wrap up with some important dates coming up in the future. And now I'd like to hand it over to Sarah.
Thank you very much, Francesca, and thank you all for joining. This is an AIM3 open office hours, so we are going to give some updates, but we actually want you to share what you have done this year so far with your AIM3s, and also show you a tool. So definitely want this interactive, and please chat in the chat if you have any questions, or we will have open session where you can ask questions also. So first of all, we want to thank you from PMs, from our whole PATH team, for all of your time and all of the work that you put into this AIM3 so far this year. We aren't done yet, but we've noticed that there's a lot of effort that you've put in for your process improvements, driven a lot of innovation in the hospitals. And most importantly, what you are here for, and we are here to help, is to enrich that coordination of care for your patients. Just so you know that with this project, IHS and PMS leadership are apprised of the work that's being done, and they are really excited to see and know more about what results have occurred, and to be able to teach about this emergency and inpatient care through the IHS hospitals. So a big thank you to everyone, and we really appreciate all of the work that you're doing, and we have enjoyed working with you too. So next slide, please. So in an AIM3 LAN earlier this year, I wanted to thank a few more people too. In May, there were several hospitals that shared in reporting, and they reported the status of their care transition measures, addressing what their current state was, how they were integrating into QAPI program, and then what their next steps were. This was early on in May, and I do want to thank Denise Klipfel from Standing Rock, Tammy Allison from Crown Point, Jane Makia from Red Lake Hospital, Jennifer Moore and Myra Cousins from Gallup Service Unit, and the Chin Lee Service Unit for sharing in the past, because I think this really helps with all the other hospitals. So we asked, Myra Cousins has offered to provide us an update on the Gallup Indian Medical Center progress with this AIM3 care transition. She is a process improvement clinical coordinator and has been very involved in projects around, I believe, the data collection analysis improvement for their patients at the hospital. So Myra, would you please take over? You can go ahead and unmute, and we look forward to learning from your experiences.
Good morning. Hello from Gallup, New Mexico.
Good morning.
My name is Myra Cousins, and I'm the clinical PI nurse for Gallup Indian Medical Center on behalf of our quality department. First, I'd like to commend our ED team, our case management team, and healthcare teams that were involved with the success of the PATH AIM3 initiatives. So thank you for your ears and eyes today, this morning. Next slide. So we ended up coming up with the PATH AIM3 measurements like you had mentioned. And when it came to implementation, it was the structuring the design specifically for EHR templates for the discharge teaching, the purposeful sampling in the ED for post calls, and the quota sampling for the inpatient discharge to review the discharge templates. With the implementation, of course, and it's also going to be mentioned in the barriers, is the buy-in. Initially, we had been given these measurements, but not a lot of teaching as to the purpose of why. And that came along with the training of staff, who will be doing the calls, who will be doing the audits, delegating responsibility for each of these measures, who will collect them, when, how often. And the implementation, I believe, is probably the most challenging in our facility. So with the success, we had the data collection, the case management auditing tool, the callback for left without being seen, and the inpatient having 100% callbacks, and the ED super track also being initiated in our ED department. With the data collection, the reliability and the validity, again, I'll talk about that more in the barriers. Analyzing how effective the discharge instructions to the patients, the callbacks to the patients being completed. It was an overhaul, a learning overhaul, a learning curve. When it came to the barriers, whew, the data is still being scrubbed for integrity. Many of the ED flow times are manually entered into the EHR. So take, for example, you have 5 different providers or MSAs putting the data input in. Our dilemma is, are they putting it in the same way? And again, that comes with education, standardizing it. We're still not reaching 100% of our callback for the ED to discharge home. Again, these are all learning points for us to improve on. Another barrier is meeting the 48-hour callback. I know that's a goal, but the issue with that is specifically on the weekends, because that's when we have more of our left without being seen occurring. So we do call them back within the 72-hour period. Again, the barrier, the buy-in. Why are we doing this? Who's going to do it? With the education, we were also learning in that process as well, coaching our teams and figuring out what is the purpose of not just gathering the data, but how will it affect our patient flow, our patient safety. So when it came to the impact, the process measurement to outcome measurement, we were more process focused, but then based on the data that is coming back, interpreting that data, how are we going to improve? What is our outcome activities? How are we going to address that? So again, that was a learning process. And you could see the paradigm shift now, where instead of just reading the data, how are we going to work with that data? And what is the purpose of it in regards to our facility specifically? So with the next step, going to outcome measurement, we're looking at readmission. How is that going to affect the PATH AIM-3? How is that going to affect the readmission or the patients returning back into the ED? So the length of stay does affect the patient care when it comes to these measurements. Next slide. So with the imperative, there are so much data that we are collecting with our ED. And we have so many data points that with having PATH coming in, they added some indicators to our data that would impact our outcome of patient care. We focus on flow quite a bit here, but adding these new processes for calling back patients, completing 100% discharge instructions to initiate and make these improvements, how we educate our patients, and what questions we ask with left without being seen. It gives us more information on how to take better care of our patients through ED flow, post-discharge, and how do we minimize patients coming back with these callbacks. So with the callback and discharge instructions, they're now our priority when it comes to our ED QAPI meetings. And the ED QAPI, we have those meetings every other week. So not only do we discuss metrics that we're following, but we also included the PATH AIM-3 measurements. How is that fitting in? So we incorporated case management, so much more in these discharge follow-ups, both inpatient and within the ED. With the initiative development, the left without being seen, the callbacks are now being analyzed much more. There are times we end up filling in for them, and it's great to be doing this at the firsthand. I had to do a callback. It was like, well, what do I do with a patient who never came back in or who left without being seen in the emergency department? And, I had to work and collaborate with case management. This patient didn't come back. She doesn't know where to go. Can you help me out? So trying to connect these patients coming back into the healthcare system, just seeing it firsthand, it does make a big difference. The education templates, they're reviewed because we do have these templates when we do call these patients back. How can we improve with even standardizing and adding more meaningful information with these patients to understand their post-discharge instructions as well? With sustainability, oh gosh, that's also taking a look at, with all of this data coming in, how valid are these data? With like CMS core measures, GIPRA, they're all standardized across the board, but yet when it comes to these PATH AIM-3, and I know I've questioned it before in prior calls, how do we define our data? How do we define the definition? And the question was answered, well, it depends on how your facility wants to define it. So each of our facilities could be measuring the same measurement, but the definition of how we define it with each of our facilities are possibly different. So I think with that sustainability, trying to cross-share benchmark would be a little bit challenging. Let's see. With the ED QAPI reviews, PATH AIM-3, there is data coming in, the analysis, the action items, post, all of these reviews, and it's reported to the program. With PATH can assist with the sharing best practice. What we mean by that is automatically just saying, hey, this is the best practice for other facilities, from these facilities that they're doing. Here you go. This may help you out. I know we do calls monthly, but how do we network with those facilities one-on-one in regards to the sustainability of the PATH AIM-3 measurements? So I know I only have 5 to 7 minutes, so we kept it minimal when it came to these implementation plans with Gallup Indian Medical Center. So if you have any questions, I'm open to that. That pretty much concludes the presentation in regards to Gallup Indian Medical Center's PATH AIM-3.
Well, thank you very much, Myra. And if there are any questions, please feel free to unmute your phone and ask the question. All right. Well, I do have something as far as you mentioned on the sustainability, and I think it was a really good point, is the definitions and how maybe some facilities, for example, are identifying their follow-ups, not necessarily left without being seen, because those are there's more specific specifications on what a left without being seen is, but more of your EDs, and if they have discharge plans and follow up within 2 days and all that, because that can be a big conversation and can continue on and on about what we really follow up on. Did you come up with any specifics on that measure that you are following at Gallup?
In regards to ED discharge patients?
Yes, that follow-up measure, yeah.
Well, I know that we are still in refinement, because with the ED QAPI, we have ESI levels 1, 2, 3, 4, and 5, and defining which ones to follow up with. But yes, there is a defined patient population that ED does follow up with.
Okay. Yeah, so that is the one thing that, I know we have been asked as PM project managers from PATH to help with identifying that too, so.
Oh, with that, we only do the discharge home templates from the inpatient discharge, not specifically for the ED, because I know that's still in refinement.
Okay. All right. Well, thank you very much. Any more questions? All right. So I want to thank you very much for taking time to share the stories that you have at the Gallup Indian Medical Center and putting this together on short notice. It was very much appreciated. And looks your facility, I have been told, has done some wonderful things, and it looks like it also. So thank you very much.
Thank you.
All right, next slide, please. So you didn't have questions, but I want to give an opportunity for everybody to open this session for hospitals to share how they have used these measures, or they've worked or analyzed their data for implementing improvements around patient care and patient coordination. So is there anybody that, any specific items you have done, activities? Don't be shy, please. I'm not going to pick on anybody, but so Francesca, if you go to the next slide, I'll have an example. And so from discussion with project managers, we were trying to identify from them working with the hospitals some of the interventions that were done and improvements. And so one of the areas in general, we were talking about follow-up calls, looking at ED and discharge and inpatient. And we noticed in many of the hospitals, there was a big trend up very sharply whenever it looked like they had done some kind of intervention. So what we found out, and not all from the different hospitals, was the interventions which are bulleted here, like facilities utilized the inpatient supervisor or ED nurses for follow-up calls. They assigned a nurse each day for callbacks. Another was enhanced chart review and tracking of the log. And so just through this AIM-3 follow-up measure and defining it in the process, they updated their chart review that they already had. They included inpatient ED follow-up in their chart reviews because they hadn't done it before, and then implementing a template to identify follow-up required by care case management. So in some cases, they actually used a template or they did something with their IPL. What can be the outcome from that is, of course, you'll see and I think Myra had mentioned that too, was they're going to start looking at their outcomes as far as ED utilization and inpatient reducing, because you're working with your patients and following up with their care. And then also a big thing is the PCMH for your hospitals, because I know everyone is embarking upon that. And this care coordination is a big part of PCMH requirements too. So anybody have, for this one in particular, do you have any aha moments or anything you can share that could help facilities?
Hi, Sarah. This is Alana Jarman. Can you guys hear me?
Yeah, thank you.
So I just kind of scrolled through some of the participants to see if there's anybody on from Crow Service Unit. And if anybody is, just go ahead and interrupt me. But I guess I think they were okay with me speaking on their behalf for this process for the follow-up phone call. Initially, when we started working on AIM-3, we got together as a team, and I think that's one of the important pieces, I think, with all of the work, whether it's AIM-3 or AIM-2 or any internal processes within your organizations, is looking at how you come together as a team and decide on a process. Because I'm sure, as everybody can probably nod their head and agree, we all wear multiple hats, and it gets kind of strenuous on our day-to-day tasks that we consider priorities. So one of the first things that we did with Crow is we got together in a conference room, and we pulled in the case managers, we pulled in the inpatient, outpatient supervisors, ED supervisor, and we identified the measures for AIM-3 And we just went through and asked each one of them who collects what, how do you collect it, what kind of template to use, so everybody kind of knew what was already being done. And then from there, we identified who could do each one of those parts. And then, so going from there for the follow-up phone calls, we progressed into that and talking about that process. And so they did an excellent job with identifying who in the facility has that ability to take on that task. And again, a part of that process was identifying ways to kind of lean up that process and to not make work smarter, not harder. So we identified that in that process of a chart review, when we are going to collect that measure for AIM-3, is that when you go into RPMS, if the patient is not coming in for an actual in-person encounter, if you open up that chart, it generally populates as a chart review encounter. So when you do a chart review, you're looking at notes within that chart to see if there was any telephone calls made, right? And what would populate as a chart review, which was very hard for the staff to delineate whether or not a follow-up phone call was made. So they worked with their CAC in order to make a template and kind of rename that. So when they looked in there, they could tell if somebody had followed up with that person from the ED. And so it's just little things like that that really, I think that team coming together and sitting at the same table and not kind of siloing each one of their work is a huge takeaway for Crow Service Unit. So, and I see there's somebody else that wants to share as well. I think Claire Moore.
Yeah, thank you, Alana, very much. Stephanie, go ahead and unmute.
Can you guys hear me okay?
Yes, we can.
Okay.
Thank you.
So at Claremore, I know that we met with Lawton and other service units at area office here in Oklahoma and developed our own priority callbacks because we had the same problem. We weren't sure who we should follow up with. We really needed to define who our patient population was that we felt as a group were at most risk. And so we focused our efforts on anyone who is left without being seen, AMA patient, anyone who has eloped that was a high risk, of course, they're going to be called back. And then we added anyone that's under the age of 15 and anyone that's over the age of 65 that is discharged to home. And then as a secondary goal, we added that we would like to be able to call back all of the level 3s that are discharged to home. And we haven't been able to meet all of the callbacks. We've ran into the same issue as everyone else. We don't have enough staff to call back that many patients and continue seeing that many patients on the daily. So what it really breaks down to is we call back the ones that are most critical, and you kind of have to triage your callback list to accomplish that and go through. And if it's like a child that's a level 5 with a rash, they probably don't need called back as much as a 72-year-old who went home with newly diagnosed high blood pressure or AFib. So we have to kind of triage our callbacks sometimes because there's just not enough time in the day to call all of them back. And they do get called back. It's just it may not be within that 48 business hours that's required. Does anyone have any questions about the process that we do here at Claremore?
Well, this is Sarah. And one of the questions, have you seen any, at this point yet, any outcomes from that? Like as far as, do you actually feel like the patient care side of it, you're getting feedback or?
We incorporated into it a survey because we weren't getting very many survey returns. So we actually incorporated into that callback because I wanted it to be meaningful and have purpose. And the other person had mentioned they didn't feel like they were having buy-in from their employees to do the process. One thing that we added to it was we added a quick little 2-minute like patient satisfaction survey that's optional. Just ask them if there was anyone that really stood out that took care of them on their visit. after we had discussed their care, of course, and then just ask, you know, did the staff wash their hands? How would you just rate the physician's bedside manner on a scale 0 of not good to 5 being good? That kind of scale. We just have a script that they read. It's a brief little 2-minute survey. So that kind of increased the buy-in because you get some feedback, good or bad.
Yeah, no, I mean, everything is helpful, so that's great. Yeah. Thank you. It's a good idea.
You're welcome.
Yep. Any other questions for Stephanie? Anybody else want to share specifically follow-up or anything, any of the other measures? Okay. Thank you again, Stephanie, for stepping up, and thank you, Alana, for the story from Crow. We really appreciate all of those. So, all right, we'll go on to the next slide, and I think we're going to get into the AIM-3 measures and the tool. So, Artis, it is your floor.
Hi, everyone. I've had the pleasure of interacting with a lot of you as part of our AIM-3 collection. So this is kind of a recap of, we've got measures that you can get out of ED dashboard if you're using BED, and then we've got measures that really only come from chart review or from business process review, because they're just not part of the encounter itself. They're part of how you follow up on that and how you do process improvement with that. So we just wanted to have a little bit of a opening up for these measures. What does reporting look like for that internally going forward? And that's kind of the point of the presentation today. So Sarah, I feel like there was something else that I was supposed to mention about this. Can you help me out here for a sec?
Not that I can think of, no.
Okay, great. Then let's look at the next slide. So when you think about how you might embed this at your service unit, at the moment, the PATH project is kind of doing a lot of the validate and report piece of this. And we want to offer you some tools and tips for how to develop the expertise to do that in-house. So this is kind of a flow chart of how you would stand up this process. So if you've got opportunities that you want to be able to work on, these are the different activities that folks would need to do, that you would need to assign somebody to be responsible for this. And this kind of comes back to what Myra was saying earlier about one of the barriers to implementing a process is understanding who's actually going to do it and when and what that looks like and how they record it. The value of this is to be able to fold this data into your process improvement. It's not about collecting it for its own sake. It's about, as both Myra and Stephanie have told us, and as Alana has mentioned as well, it's about how do you use this to improve patient care. So it's not some kind of abstract spreadsheet that never goes anywhere. It's about how do you incorporate this into improving patient care, because that's what it's all about. Could I have the next slide, please? I would like to show you something that we have developed. So we're going to be making this tool available to you next month, and I think it's going to be towards the end of next month. This is a tool that you can use internally. These are the same measures that we've been looking at for AIM-3, but this is at the moment we've been asking you to supply it to us in PDF, and I do not have any information about what that will look like next year, but we really wanted to make sure that you had the option to be collecting and reviewing this internally. So this is a tool for doing that. If you look at the layout here, you can see there are some graphs here. This is in a print-friendly format, and this is assuming that you don't have a bed available and you're doing all this collection through chart abstraction. We also have a version of this that you can just copy paste your bed extract in, and it will pull everything that it can from that. So it will pull your throughput times and you're left without being seen. But this is providing a tool for those folks who are doing it all from scratch through chart abstraction directly. So this is where you can see the results build up over the course of the year as you enter data for it. Let me show you how you would actually enter the data and what it would look like. So the idea is that you might be recording anywhere from, up to 25 charts, and that for each one, you're going to be looking at the different measures, the different data that you need in order to collect all the AIM3 measures as it applies to this encounter. So I'm just going to scroll to the right here. And you can see all these measures that are very familiar from doing the AIM3 data collection for ED transitions of care. The other thing that you can do in here is just directly enter these in. And if I just enter in some sample data here, so I've entered in some sample data. You can see that I'm on the January worksheet. If I go back over and look at this summary worksheet, you can see that it has showed up here with the values that I have put in. There's a separate sheet for each month. So when you jump in here and put the data for each month, it's just going to aggregate it for you on that front page. And it's going to produce it both as a table, so you can see the values there, and also as a chart, so you can see the trend over time. And speaking of trends over time, this is something else that I would like to show you that we've put together for you. And we'll be sharing this as well. So as you're probably all aware, we've had a process in the last few weeks quite intensively where we are working really hard to ensure that the data that we report that is aggregated for all PATH hospitals really is as accurate and clean and favourable as possible. Favourable in the sense that we know that folks have made a lot of improvement changes that are impacting patient care, and we really want to make sure that we are clearly surfacing that excellent performance. And one of the things with that is checking out the data to make sure that it is accurate and to make sure that it makes sense. And this document is exactly for that. So I think, Sarah, I think we do have a slide for this, but we can skip past it when we get to that because I'll speak to this in a little bit more detail now. The basic idea of validating data, if you haven't had much experience with it before, is super simple. Essentially, you're looking for, does it make sense? So in the first instance, when you look at a chart, such as one of these charts here, we'd be looking for, are there any sharp changes or are there any gaps? So in this, if this were our real example, we'd be going, wow, why did that suddenly drop in March? And then why is it 0 for the rest of the year? Now that could be because we haven't got the data in there. It could be because a process changed and not in a very good direction. When you're validating data, you should look for gaps and you should look for sharp changes and look to understand why each of those are there. If you've got questions about this, please feel free to put them in the chat now, and I will also pause for questions at the end of going through this document. So the other thing is, look at the numbers. Does it actually make sense in terms of what you know about your hospital, your ED, your patients? and your processes. So are you expecting to see an improvement because you've implemented a process where left without being seen patients are being followed up more or more quickly than they were before? In that case, you would expect to see a change in the data. So it's about looking at how does this fit with what you know about what's happening in your hospital. The other thing is, when you've got a set of records, keep track of the number of records that you are working with. Just to make sure that you don't drop any, because if you are working with a big list and you accidentally filter something out, then your data can well be inaccurate if you have accidentally filtered out the wrong thing. So when I am processing bed extracts in particular, this is something that I do to keep track of, here's how many records there were altogether. Here are ones that I had to exclude for this reason or this reason or this reason, and just making sure that the math adds up. That matters more when you're looking at a whole big set of records and trying to calculate something over like a mean or a median over that whole set of records. When you look back at this example here, we've built logic into this spreadsheet that is going to help do some of this kind of data validation. For example, we've already got calculations in here that will pick up median and mean times if you've populated this data in here. We've also got logic in here that will let you know if you try and make the numerator greater than the denominator. And let's talk about that for a sec. When you look at a rate that is, you're looking at a particular set of patients and whether something happened for those patients, it can't possibly be more than 100%, right? If every single patient had the benefit of that process, then it would be 100%. If you see something that's more than 100%, often what it is that the numerator, so the one on top of the fraction, accidentally got switched around with the denominator, which is the one on the bottom of the fraction. That's worth checking for. Also, if you are looking at left without being seen rates, and you're looking at left without being seen follow-up, the group of people who you're looking at for left without being seen follow-up are exactly the patients who left without being seen. There's more detail about this in the written document than I can readily speak to in this session, but I will be here afterwards if you've got questions. I can just stay on the line, and I'm really happy. I mean, those of you who have met me before know that I can talk about data for hours. Another way of validating specific records is when you're looking at throughput times, there's a relationship between them. The length of stay cannot be more than the time to triage, and it cannot be more than the time to a medical screening exam. And all of those numbers have to either be 0, we hope their length of stay is not 0, but they can't be less than 0. They've got to be at least 0 or a positive number, because people can't leave before they arrive, and they can't be examined before they arrive. So if you see negative numbers, that's usually a sign that there was a mistake in the data entry. Likewise, if you see super long length of stay numbers, sometimes that's true, but sometimes it's actually where somebody made a 12-hour or a 24-hour error in their data entry. And you know, we're human, this happens, but if it's happening a lot so that it's interfering with the capacity to pull these valid numbers to calculate things like median length of stay, which is strongly correlated with the quality of patient care. If it's happening a lot, then that's an opportunity to look at who's doing that data entry and look at the process and the barriers that might be preventing that person from being able to do that accurately. Is it the situation that they don't have time to do it as they are actually encountering the patient, and so they're doing it later? Is it that they're not aware that it's a 24-hour clock, not a 12-hour clock, or whatever it might be? And there are lots and lots of reasons. You know, as an analyst, I always think that data can't tell you why, it can only tell you where to look for why. and you know where to look. That's a really good start. It can be hard to get otherwise. But comparing the different times of an encounter and making sure that they make sense with respect to each other, that's another valuable way of seeing how clean that your data is. So these are the things that I wanted to share with you today about recording and validating data. Do you have any questions or comments? What has been interesting or successful or maybe difficult about doing this kind of validation at your own service unit? So I think we're up to the next slide and possibly even the slide after that.
Francesca, could you, I wanted to go back a couple slides on that workflow and just make so on this one, as Artis had said, we have those tools that will be posted on a website in January. But what it is I know that some of your facilities have their own, and it processes, you do your chart abstraction and it processes through and makes your charts yourself. But others may not have that tool. So the way this was developed, and as Artis demonstrated, you can use it to that point of chart abstraction, or you can use it as I already have my numerator denominator, and just put that in. And so this is showing you the ORs and all of that. I don't know if it's confusing, but that's basically what it's saying. It's a flexibility on how you could use these tools that will be available for you. All right, any questions? All right, go ahead and go forward, Francesca, please. We wanted to note some important dates. So we are gathering data so that we have a complete year of the AIM3 data and showing that trend for the complete year. So the November data, if the PMs have not sent that out yet, that they will be, as noted, you know, the deadline is normally the second Friday of each month. And then we have turnaround on when we get the draft reports, and then review for corrections, and then official reports. So that is the November dates. And for December, it is going to be much condensed at this point. So we have put in as the Monday, not the first Friday, but the Monday after that, if we could please get the data on the 6th, and turn around and do the draft forms, the draft reports, so you can review them. And then the official ones will be out on the 16th. So we are doing more of a condensed version of the December data for reporting in January. So just wanted to share that with you. And again, the tools will be available. That's for your data collection, data generation, report generation. And we're targeting the 25th to have that out on the website. And we'll certainly get an email out, or we'll work through the PMs on that. And as far as you making sure you have those tools. All right, next slide, please. Another important date is that we do have the PCMH open office hours, and that is scheduled for Monday, December 9th. You can see the different times depending upon what time zone you're in. And it's going to be facilitated along with the IHS, and looking at innovating ideas for PCMH standards. Ben Feliciano, which all of you I'm sure know, is from the IHS office that's going to be working with one of our PMs on this. Also going to take a look at the portal and how you can use that in your care. So please make sure to sign up for that. And if you haven't gotten the invite, contact your PM, and they'll definitely give you, send out that link to the open office hours. All right, and the next slide is just, I believe, a thank you for joining us. And if there's any questions, please put them in the chat. If there's anything you'd like to see Any follow-up, please let us know. And if you'd like to unmute, you're welcome to unmute the phone too. All right, I believe there aren't any questions, but please reach out to us if there's anything we can do to help you. And thank you again to Myra for speaking for us, and all of the others that provided, Stephanie and Alana, and providing their stories too. Have a great day, and thank you very much.